Good afternoon, everyone. This is Megan Fournier with the Home Care Alliance of Massachusetts. Thank you all for calling in to today's webinar. I wanted to go over a couple of things before we begin. The first thing is that everyone's going to stay in mute only for the sake of convenience and so not get any side conversations. If you do have questions, we'll save them to the end, but you can write them in the sidebar under the questions tab. And then once they're done with their presentation, we'll address them. And you can write them at any time because they'll be saved and we'll go in order of the questions. Lastly, this webinar is being recorded, and once it's processed, it will be sent out to everyone, most likely tomorrow morning. So for some reason, if you have to leave or you want another staff member to listen to it, it will be made available. So with that, I'm now going to hand it over to Andrew and Russell, who are today's presenters.
Thank you. My name is Andrew Bronstein. I am the CEO of ClinLogica, and ClinLogica is a company that does data analytics in home care and hospice. Some of you may know me from my past life where I was the co-founder of ClinLogica. I am very pleased today to be joined with Russell Lusak, who's one of our customers in New York City with over 20 years experience across the spectrum from home health, LICSAs, community services in again, New York City. And he's involved in the boards of multiple different government programs. And I think he will bring a very interesting insight to data, not just how home care and others are practicing today, but some of the things that are going on with social determinants or other things that are going to drive some of the future outcomes going forward. So, Russell?
Thank you, Andrew, and thank you for having me present. If you could just go back for just 1 second to that slide. Just one thing I wanted to kind of help shape the conversation is my involvement, of course, with HCA for New York State. I'm on the board there, but because of my involvement with HCA, I've been asked by the state of New York through the governor's office to participate in 2 statewide committees to help shape and transform home and community-based services here in New York around value-based payments. So in my bio, you see there the one about New York State Department of Health's Transparency Evaluation and Health Information Technology Work Group, and then the Social Determinants of Health Work Group, both reporting here in New York State to what's called the Value-Based Payment Work Group. It's important because, as that work effort's been moving forward, self-help is trying to figure out what exactly we need to do here internally in order to position our programs to the changing market here in New York. So the next slide, if you could. So a little bit about us. Self-help is a somewhat large organization here in New York City. If I use some acronyms here that you don't know, I apologize, but on the top there is sort of in the clouds are our community-based in-home services, where we provide home care through a certified home health agency, 2 licensed agencies, which are some anomalies here in New York, where we provide paraprofessionals to those certified agencies, and manage long-term care plans. We've got a very large home health aid training program, and we actually have 2 city-funded home care programs that are funded by the City of New York. One is housekeeping and one is homemaking. And then you can see on top there we also have a guardianship program funded by New York City, a social adult day program, a geriatric care management program, and then we also have funding to provide services through the local office area of aging. We call it DFTA, Department for the Aging here in New York, to provide 3 case management programs. We have 3 case management programs to provide services in the form of entitlements and coordination of benefits, bringing services to people's homes, rental subsidies, food, home health care, etc. So that's sort of the overview of social services. Social services and home care. But self-help also has bricks and mortar. We have 4 naturally occurring retirement communities called NORCs here in New York. We have 10 affordable housing complexes for seniors that is growing. We operate 5 senior centers that are also funded by the local office area of aging. And then, of course, I couldn't not say our signature program is our Holocaust Survivor Program, where we have 7 offices throughout New York City where we provide case management services and have been doing that since 1936. So we've been around for 80+ years. In all, you can see the boroughs we operate in. Our focus is to promote independent living. We do that for approximately 20,000 people here in New York City. So the next slide. So 95% of our population are on some sort of Medicare, Medicaid. And again, for many of you who are operating certified agencies in Massachusetts, when you look at the multiple chronic conditions that we have as part of our population, there's no argument. It's probably the same that you have there in Massachusetts. So we've identified them in all of our programs, all of our home care programs, all of our community-based programs, and it's a common tangent. The average age of our population is around 75 or so. So these chronic conditions are indicative of the populations that we all serve. Next slide. So here in New York, I'm sure Massachusetts is going through the same similar changes that we are, but delivery system reform, incentive payment program, we affectionately call it DSRIP here in New York. I think it was in the leading age up in Massachusetts. I saw some conversations about DSRIP there back in January. So there's a changing landscape here in New York, and what's happening is the hospitals are being asked to change the way they deliver care and to move things out into a community-based setting. Here in New York, it's interesting because their definition of community-based setting is really outpatient care. And so what's happened is it's gone from inpatient to outpatient, and what we've seen is that many of the hospitals, through their outpatient clinics, the diagnostic and treatment centers, are providing nurses that actually go out into the home, for example, to provide wound care. So here in New York, we've been working with our local association here in New York State to say, well, you can't do that. There are rules of the game for home care, and you can't necessarily have a nurse who's part of a diagnostic and treatment center go out and render care in the home. So here in New York, we're looking at how we can navigate and work collaboratively with the hospitals while following the rules of the game, the regulations for conditions of participation. So home care is certainly a key component to what's happening with DSRIP, and of course community-based care. And it's really about how do we move the needle from, and we'll see in a second on the next slide, but how do we move the needle from inpatient to outpatient, from acute care into community-based care. And what's important for self-help and what we're trying to do, and my work effort in working with the state agencies or those state work groups, is really how do we leverage home and community-based services within value-based payment? Because that's where everything is going. It's going more towards the value equation, which is based upon outcomes, not about volume. So next slide. I thought this slide was very interesting. I figured I'd share it with you. It's fairly up to date, 2016. What it's showing is the acute care spend for, well, acute care and long-term care in CMS. And it's approximately $960 billion of federal and state dollars are going towards paying for acute care or long-term care facilities. And if the initiative for the delivery system reform, DSRIP, is to move people into a community-based setting, you see on the left there, it's prevention. And right now, there's only about $2 billion that are being allocated for prevention methodologies. So if you think about that needle shifting from an acute care, long-term care, which is the skilled nursing facilities, nursing homes, into a community-based setting through the ACL section there, you find that there's a big movement of dollars that needs to come in order for us to play in this space. And value-based payment is looking at how do we move that money from that column, the right side of the screen there, to the left side of the screen there. So next slide. So here's our problem, and I'm sure you'll all appreciate it because self-help is so multifaceted. We have a lot of software packages that we have here at self-help to operate our systems here. So we've got 4 clinical-based systems that equate to approximately 10 databases to manage the programs that I described for you earlier, which creates a situation of having disparate systems. We can't normalize our data. We can't track it across all of our programs. We certainly can't identify risk populations to stratify that risk, and making care coordination really, really a tough task for us, especially around value-based payments. So the name of the game, of course, is you have to, in order to assume risk, you have to understand your patient populations. So the next slide. So we looked at it and we said, well, how do we do this? What are the steps in order to relook at your databases? And sometimes the right way to answer that question is to look at it in the reverse. And it's really what do you want out of the systems in order to describe what you want in the systems. So we deployed sort of a strategy called matrix management, and it's really in 4 broad areas. And we could expand on this, even more. But really, it boils down to looking at, and this is the value equation, looking at staff productivity, looking at program measures, programmatic outcomes, the programmatic measures, sorry, and then the programmatic outcome measures. what are the determinants of health that we measure for the impact that our program has by performing whatever we're performing. And then, of course, the determinants of health lead to health outcomes for population health management. So the next slide. So as I sit on the social determinant of health work group, one of the things we looked at, and this goes into that, the programmatic outcomes. What are the things that we do that are impactful for social determinants of health? It's not the number of visits that we do, right? It's not the decreasing decubiti for wound care. That's a programmatic metric, a programmatic outcome. But what does that outcome lead to? And that's the determinants of health. So right here are the social determinants of health. There are 5 pillars. So in New York State, we identified these 5 pillars as being critical for measuring social determinants of health. And what I'm going to do is I'm going to focus a little bit on the next slide on number 5, which is the health and healthcare. But you can see some of the ones that are really important, especially for my other programs, economic stability, for example. Poverty. In my case management programs, for example, we have a social worker that coordinates subsidized income. We provide them with food. That keeps people out of poverty. We actually put together a metric for this poverty level to determine how much subsidies we give people in the form of the equivalent of cash, and the dollar amounts were astronomical for a cohort that we were actually studying. We provide housing security and stability. We do the food security. Again, we bring people together with food stamps, which is a subsidy. We put people together with Meals on Wheels programs. Of course, transportation, getting people to and from a senior center. We coordinate all that. And I should say in the earlier slide, in our programs that we have, all of our bricks and mortar, we have social workers that are involved in everything that we do to help coordinate that, which we believe is very leverageable. And then again, look at the neighborhood and environment. Those things are all important. Affordable quality housing. Here in New York City, we have a big shortfall in housing for seniors, which is probably the #1 issue we have with getting people out of nursing homes, where it's very costly. So the next slide, I'll just focus in on number 5 for a second. So as we went through this work group with the state, and we began to extrapolate a little bit more on that social determinant of health and healthcare, we went through these primary areas: improving healthy behaviors, increasing literacy skills, vaccinations, advanced directives, social environments, nutrition, affordable housing, and then look at the one on the bottom, supplemental income through entitlements, benefits, and community supports. Really important stuff, and for self-help, that is right in our bread and butter on what we do on a daily basis. So we're looking at that now and figuring out in our disparate systems, which currently don't measure that. I mean, they talk about the widgets, if you will, how many food stamps did we get, but we don't really quantify it to determine what the outcome of that benefit is. And that's something that we're working on right now with some statewide funding we've got for this project we're working on, and we're in the beginning stages of it now. But we figured for the certified agency, what was really important, what we're really going to focus on right now, is doing predictive modeling, because part of it is looking at the business analytics. It's also looking at predictive modeling. So the focus for us going forward for our CHA are going to be depression, a falls prevention program, vaccinations, and sepsis. So how do we demonstrate, again, that these social determinants of health have an impact on the healthcare system? So this is the next slide. So we got this grant funding for the state of New York. It was not-for-profit infrastructure capital investment program. It was funded by the state of New York, and we looked at the work plans for the state on those 2 work groups that I sat on and said, okay, how do we align our programs to what the state's trying to do so we're aligned with our goals? So self-help has its goals that are aligned to the state's goals. And this is what we came up with, and it's pretty interesting because it is completely aligned with what the state's doing. I just got off a phone call earlier with the one work group, and now they're focused on social determinants of health, which is very interesting timing for us. But if you look, it's increasing our wide area network, making sure we have enough bandwidth, for example, and the capacities that we could connect to the health information exchanges that are going to be important, where the hospitals and doctors are connected, so we know where our patients are when they're in the community. Development of a customized data warehouse. Again, collapsing those 10 software packages into one version of the truth is really important for us, because without that, we can't really do the next things we're going to do, which is, well, the interfacing, of course, but doing the evidence-based programming and running predictive modeling on our data, which would allow us to do the business analytics, demonstrate the health outcomes, And then, of course, what we're looking to do here at Self-Help is to create a centralized information and referral call center so we can route people internally where they need to go. So those things are really important, we believe. And we are, again, just starting this process now. We started in January. And the goal, of course, is to assume risk. And more importantly, to participate in value-based payment, where I believe we all need to be able to play in. So I think that's it for me, Andrew. Yeah, so that's it for me. And I guess we're going to wait for the end of the presentation for all questions if you have any for me. So thank you for your time.
Thank you, Russ. That was great. And again, what we're going to try and do next is try and tie the how do we achieve what Russ is driving as the needs underlying the agency, which in a lot of ways is very different from the way care has occurred, the way EMRs were designed to run. So it is not a trivial challenge to get that from where we are today. So when we start taking a look at information such as this, today a lot of the agencies are being measured on outcomes at the level of the agency. In order to start getting down to patient populations and starting to identify how we use data to drive the way business operates, we actually have to start slicing and dicing our data in different ways, whether it's by disease state, to take a look at various COPD versus pneumonia patients, whether it's dicing it by location. So why is an office in Manhattan different than one out in Long Island? And is there some practice or other processes that's affecting different results? When you have large programs such as Russ described that are kept in multiple different software packages, it may be difficult, if not impossible, to actually know that two different programs that are administered completely differently are seeing the same patient. So the inability to leverage that data to actually know that you have two different staffers going out to see the same patient for completely different things and potentially even collecting the same or overlapping information. When we talk about outcomes, each one of you is probably sitting there in your mind and you have a particular outcome measurement system that you're thinking of. Some of you are thinking about Home Health Compare. Some of you say, well, 5-star is how we're driving our business. Of course, being in Massachusetts, value-based purchasing is not far behind because that's how your revenue is going to be. What this slide is trying to show is to take a look at how these different measurement systems overlap and not overlap in terms of how you optimize your care. Home Health Compare is, again, publicly accessible to everyone, but it is actually based on a national ranking of agencies. So the STAR system is actually based on how you do nationally. In parts of the country where a particular state tends to be above average in healthcare, that tends to mean that more of the agencies tend to skew to the higher STAR ranking than the rest of the country. When you get down to 5-star, you actually are focused on a subset of the Home Health Compare measures, a total of 9. Some of the color coding here has to do with some of the changes that either will or may happen in 2018. The interesting thing as you shift to value-based payment, there is some overlap, but there are also differences. The most important difference, though, underlying isn't which measures it's using, but the fact that you are being compared only to those within the state of Massachusetts, that there is no averaging for the other states. So even though the measures may be similar, the outcomes when it ranks you are very different. Now, any agency I talk to, of course, is going to say their number one thing is how are they going to get referrals. And so they're trying to take their outcome measures and approach ACOs and payers and say, here are my outcomes, please refer the patients to me. Now the reason we added the last column on the ACO is we wanted you to get a feel for why are the outcomes on the ACO not necessarily the same ones that are occurring in a home care agency, so that sometimes there might be a little eye-rolling when you talk about ADLs improving when they're sitting there going, well, that's not how I'm being measured. So sometimes it's very important to understand what the metric system, if not all of them, that you're optimizing for, as well as figure out who you're selling your outcomes to in order to figure out what the best set of measures are to drive your improvement changes. Everyone today has put an EMR in place, at least for billing. vast majority of people also have some level of EMR driving clinical components, whether it's OASIS only or at least some set of clinical documentation. The EMRs in general were designed to document what you did, to basically have that information you need if anyone questions the care you gave, questions the reimbursement that you requested. They really were never designed to optimize patient care. It was really a workflow management system for the back office. In the shift to value-based care or outcome management, the focus is on patient care, what a patient gets, what they need, and the question comes down to how a given information system, whether it's an EMR or other system, can drive and identify the appropriate things for a patient and help you get to where you need to get in terms of better outcomes. The majority of EMRs today, not that there's anything wrong with them, but they are not designed for case managing. They are not the underlying systems that can, drive patient care. Now, Russ talked about having 10 different databases across 4 different software packages. He's also going to be heading to tying in a RIO, so a Health Information Exchange going forward. They obviously are going to work with other partners throughout the state of New York. So what you end up having is a whole bunch of different data sources. And in the case of a home care agency, you may have patient monitoring. You may be part of a ACO in Massachusetts. It's not uncommon for ACOs to own home care agencies, and that may be a trend that continues. But they tend to have their own information source. So how do you leverage the information across different parts of the healthcare system to better manage these patients? Now, the first view would be, well, we just take all of them and throw them into a data warehouse and then look at that data. But there is a problem with that, and that is that all of these systems have different ways that they identify a patient. So it is not simple to put information into a data warehouse and say, what is the data related to Sally Smith when there are multiple Sally Smiths in different systems, and how do you identify who's the same? Information is stored in different formats. The way drugs are identified, the way labs are identified, the way vaccinations, they may all be stored in different ways that when you put them together, you cannot tell they're the same thing. So a system that collects, let's say, a depression scale might use a PHQ-9. Another system might use a different type of depression scale, and you can't basically treat them as the same when they collect information one way versus another. A great other example is falls risk. Mach 10 tends to be used in a lot of home care agencies, but other types of systems, or in terms of community systems, that falls risk is not collected using the Mach 10. As a matter of fact, the Mach 10 is specifically only supported in the home healthcare environment for which it has been validated. So there are a lot of challenges in terms of pulling data together in a ways that you can actually do some of the data analytics that we're talking about. One of the things that is common to a lot of the outcome programs is the way that is delivered to CMS, at least, is in terms of mining the OASIS data. Now, there's certainly some issues regarding the way value-based additional measures are coming, and whether that is OASIS or non-OASIS, and how that may change going forward. But the vast majority of the outcome measures are related to data that's collected with the OASIS. And certainly, home healthcare has deployed a number of different analytic products that help you with the analysis of OASIS data to drive outcomes. But let's take a look at what that means to drive outcomes. First of all, in a value-based world, start of care and resumption of care are equal quality episodes. So a patient that goes from a start of care to a transfer is equal to one quality episode, and one who comes in from a resumption of care to a discharge is another. Whereas today, a lot of people will do a lot of, let's say, 100% review of a start of care. In a value-based world, the information and the outcomes that come from the resumption of care also are just as equal and valuable, and that is different from the way things have been measured previously. The other thing to understand is the majority of the outcome measures are actually collected based on discharge data, not based on the OASIS you do at start of care or even the recertification. Now, what that means is that information may not exist in your system until after you've discharged the patient in the majority of cases, or in the case of a hospitalization, almost definitely does not exist until the patient has actually ended up in the hospital because you didn't know about that before it happened. So if the information you're collecting that drives the outcomes is collected after the incident occurred that has a negative outcome, how can you better manage your outcomes and not just live with it is what it is? And the answer is we can actually start changing the way we look at data. So let's take a look at different types of data, different time frames of data, and how we can use data to start changing that perspective from a retrospective all the way to a prospective look at data. The data that CMS ends up publishing, whether it's in home health compare, value-based programs, and depending on the measure, can be easily 6 to 9 months old by the time it's published on the web or provided to a given agency. Now, that's both your data as well as your competitors' data. So when you start taking a look at benchmarks of how are you doing versus your competitors, you're really answering the question of how was I doing versus my competitors 6 to 9 months ago. It's not really answering the question of how are you doing today. Now, it is certainly possible to model that data and to take a look at what you're doing in terms of those measures before CMS publishes their official data, and to take a look at your trending of how are you doing basically on OASIS as you've already completed. And then the next shift is to start saying, okay, well, is there a way to track what I'm doing with patients that I currently are managing today that may not have a completed episode where an outcome measure exists? So not looking at what happened at discharge, but taking a look at the current, what patients am I seeing today, and I have not gotten to a recert or a discharge. So how do I look at the data of where I'm trending to see that I am going to get the best possible outcome I can achieve? And as Russ starts talking about with modeling, the next part is also saying, can I look forward beyond data that I've already recorded to try and figure out what may or may not happen based on a combination of risks that we've identified, based on data trending we're seeing, and try and find ways to model that in ways that we can identify not only the populations that may be at risk, but what it is that we can potentially do in terms of the management of the care to change that risk. It's one thing to say that a patient has a high risk of a hospitalization. It's another to say, and I know what to do to change that risk of a hospitalization. We know that healthcare is shifting a lot in terms of who owns what, who owns outcomes, the relationship to post-acute care, pre-acute care, community care, and all of those types of different silos for which you may be practicing care. Physicians or ACOs in general have not been really successful in terms of shared savings. And one of the reasons they have not been overly successful is because the approach that's being used to identify measures and their care actually requires more than what they're able to bring to the table. So if you take a look at a typical patient-physician experience, you're talking about a patient who may see their primary care physician between 1 and 4 times a year, probably for 15 minutes at a shot. So that's a total of 1 hour over a year. And there's only so much that that physician can do in terms of identifying and managing top-level issues. There's a great opportunity for nurses in home care agencies to work in more of a nurse navigator model, which has actually been shown to greatly improve the shared savings and success of ACOs, both on the upside risk and downside risk, in terms of the fact that you are sitting with these patients between 10 and 20 hours during a typical episode, which is between 10 and 20 times as much time with that patient as a physician spends in an entire year. You know more of what the alerts and issues are, and there are ways to use the skill of the clinicians to bring a greater level of care to that population and to offer a different set of value to the primary care or ACOs that are actually able to be done today. Now, are the reimbursement models all there fully supporting this? Obviously not. Part of the shift going on is we're sitting between 2 different reimbursement models. But it takes enough years to start switching this and building the models that those who will be successful with this going forward are at least making the investments in how they achieve this and trying to build the partnerships and different types of programs to take on parts of these challenges, whether it's helping the physician achieve med reconciliation, helping physicians focus on driving down the hospitalization or medication issues. There are various different ways that these types of programs and data can be used to improve the overall care process and better align you with the primary care organization. And in some way is a new way in which people will be selling their services going forward. Now, when we take a look again at a 5-star, that's basically ranked on how are we doing versus everyone in the country. Now, CMS publishes the data for every agency in the country. So we're actually able to take that data and take a look at within a state and say, oh, well, if this is where you did nationally, we can project what your star ranking would be if it was actually compared to just, let's say, the state of Massachusetts. Now, the interesting thing is, if you're, let's say, in the Boston area, you're not really competing against the agencies out in Western Mass in terms of your referral sources. So if they're looking at a subset of the agencies that are in the state, i.e. those that are in their local area, and they're using this data to identify their kind of narrower networks, which is what a lot of, again, insurers and ACOs are driving towards, do you have the ability to use the same data to project how are you doing versus the people you're actually competing with day after day in your own area? Now, there are a couple different ways to take a look at this data. One is to take a look at how you're ranking on a percentile basis in your state. The other is to take a look at your trending, and that is how are you doing relative to your competitors. So we could say that a particular measure, you have been consistent at a 99.7% compliance rate, but is that getting better or worse, or are your competitors improving or getting worse in that measure? So how are you ranking relative to them? One of the other things that actually ends up happening is agencies are focused on improving these measures. So a bunching effect happens, which says if we're focusing, let's say, on getting depression screens right, because that's an outcome measure, all of the agencies are focused on getting all of those I's dotted and T's crossed, making sure they don't miss a measure. The side effect of that is you have graphs that look like this, where the vast majority of the agencies score 100%. Now, in an environment such as this, missing one patient means that you're now in this particular measure in the 61st percentile, because all the others are tied at 100%, and as soon as you miss one patient, you're outside of that tie, and you immediately drop to the bottom of that. So it is very, very different environment where you can miss many patients and still do well. We're getting to the point that it has to be a manufacturing process with zero defects, especially on things that are process-oriented, that people can put systems in place to make sure that they don't miss things. When you take a look at your key performance indicators, and again, these are the same measures that you would either use for 5-star or Home Health Compare, there are many different ways to look at it. In this particular graph, what we're doing, the green and the red, is actually relative to the rank of a particular agency in the state of Massachusetts. So looking at data only relative to your cohorts. The other thing it's trying to do is break it down by site, so you can actually start taking a look at whether or not it's particular sites that you're managing or processes within the sites that are contributing to why you are missing things. And even drilling down to the level of the patient, so you can identify which patients and which episodes for those patients are causing your negative outcomes. We're working with one agency that's going back over all of their 2016 data to make sure that all of the patients that actually contributed to a negative outcome that will affect their value-based purchasing score, i.e. the revenue in 2018, that there were no mistakes made and that the documentation really does not support that negative outcome, and that if it was a mistake where the documentation supports a different outcome, that they're able to go back and correct each of those individual OASISes and greatly improve how they would rank in how CMS calculates their VBP score. We talked a lot about how we switch to proactive from reactive data. And let's talk about a specific example with pneumonia vaccination. Depending which measure you look at, pneumonia either is a measure that for which you're being judged on outcome or it's not. It's not necessarily on 5-star, but it is on value-based purchasing. It also is on physician ACO measures. Now, there are a couple different ways that we can look at this, which is the letter of the law and the intent of the law. And by law, I don't literally mean the laws, but why CMS writes an OASIS question the way they do. A lot of agencies will look at a pneumonia and say, if there's any pneumonia documented for a patient, that they will mark it as completed. And if the patient is under age 65, they will say it's not age appropriate. Now, that's not necessarily the intent or the CDC definitions of a pneumococcal vaccinations. First of all, you actually have two different pneumonia vaccinations, a PCV13 and a PPSV, which most of you know as Pneumovax. So if the patient has a PCV13, do you count it as they got the OASIS or not if they did not get the Pneumovax? You may be able to say you did it, but in the end, if the question is, did you do what you could to help reduce the hospitalization and ER usage, a patient that ends up with one of the pneumonia viruses that are actually covered by the Pneumovax could have avoided that hospitalization if the patient got the right vaccination. Likewise, patients under age 65 have different high-risk conditions, and CDC defines a whole set of high-risk patients for which the pneumonia vaccination, the PPSV, is appropriate. Making sure that the correct patients get the correct vaccination, although also helping you with the pneumonia outcome measure, is also critical to your success in lowering your hospitalization, ER usage, rehospitalization, any of those metrics, because these are the high-risk patients that will end up in the hospital and end up in the ER. A typical pneumonia patient tends to end up in the hospital at a vastly higher rate than COPD heart failure patients. So the question is, how do you best manage? Are you managing to the numbers? Are you managing to a single number? Or are you managing to the net effect of how you improve healthcare? And how do you use your data to identify in advance which patients are getting what and which ones are you missing? When Russ was talking about his first slide that took a look at how Cell Health is put together, one of the things you notice is he has a lot of different verticals that he's dealing with. And we can treat all patients the same, or we can actually start taking a look at populations that may have specific programs around them, programs that we're targeting certain subsets of the population. Now, it could be a COPD patient. In his case, it might be certain Holocaust survivor patients. It could be people that are in public housing. And how do you segment your people within those verticals and identify what are the metrics that you're measuring, monitoring, and using to manage that population, which again may be different as you look at these different disparate groups. The way I manage a COPD patient is not the same as how I would manage heart failure patients. It is certainly not the same way I'd manage at-risk diabetic patients that are in a poverty line within public housing. When we're looking with data prospectively, the first thing we need to do is identify who are the patients that we're actually trying to identify. Is it based on patients that don't have ADLs improving? Is it based on a stratification of risk? For instance, if you take a patient with a high falls risk versus one who has a medium falls risk, the first perspective would say we focus programs on patients that actually have a high falls risk. But actually, if I tell you that that patient with a high falls risk has been high falls risk for the last 10 years, and the medium risk patient has been 0 risk last week, you would actually decide that the patient with the change in risk was the one that you were most concerned about. So sometimes static stratification of data is less important than understanding the change or acceleration in that data and who's unstable. So that helps us best identify the patients that we're worried about. The next thing we want to really do is identify how are we treating them. Now, this is not just talking about a 485 and physician's orders. This is really understanding what is going on visit to visit. How do we identify changes in conditions? How do we identify gaps of care where we want to go back to the physician and say, you know, we're missing something here, or this patient is a high risk for the hospitalization, and here's what we think we need to do to improve things. Or even in the case of value-based care, the patient's admitted for one thing, but since the patient has multiple chronic care conditions, they may be a wound patient, but they end up in the hospital for their diabetes. So the way we manage what the risks are today is very different than the way we did it before value-based care, where we're really focused on what did the doctor ask us to do. Finally, we have a quality process. We may say this is what we do and this is how we're going to handle pneumonia or other types of things, but then the question is, do you have the data to identify the deviation from that process, to identify when patients aren't getting what they need, to identify when a clinician may not have done something? It's an interesting thing when you take a look and see why hospitalization occurred and figure out that that was because you actually had a supervisor who took a 2-week vacation in the summer, and her job was to manage the COPD patients within a particular organization, and there was no escalation of that management process when she was not there. Processes like that are extremely fragile. They are not scalable, and they're not possible to drive high outcomes where you have individual people who own processes like that. Now, Russ talked a little bit about why he's doing analytics, and I want to try and give a little bigger perspective of the type of ROI you can get using analytics. We talked a little bit about, and you all know that insurers and ACOs are moving to more narrow networks. So having outcomes and outcome measures to demonstrate to them your outcomes, both in terms of the way you're measured as well as in the way they're measured, can help get additional referrals. You can automate some of the manual QA and other processes that you're doing that cost a lot of manual labor in the back office. You could potentially even reduce enough overhead that it's the same improvement as you got when you deployed an EMR. So a lot of the way in which you're going to be able to streamline your efficiency is by taking a lot of manual processes that are more clinical than paperwork and automating and using data to drive which patients that you really need to look at, or whether or not information is necessary to drill down deeper. It helps the staff better focus on the treatment rather than gathering data. Lots of agencies spend time manually going through every chart or reading every note from a particular patient. We also know very well that being in a value-based state, that by 2023, which is, believe it or not, only 5-6 years away, there will be a 16% revenue difference, revenue, not profit, between the best and the worst agencies in the state. That is a huge margin. And in order to get there, again, the notion of how do I really drive my care by state benchmarks versus national benchmarks. And even those who aren't in a value-based state today or have operations that are not in a value-based state, what's going on in Washington, both in terms of politics as well as in the demographics of the baby boomers, are potentially going to put national spotlight on value-based care rolling out sooner to more places than it is today. If CMS ends up with a 2% cut in their budget, they have to get it from someplace. And they will generally try and apply either a push down on rates across the board, but a more palatable solution is for them to push the rates down across the board and then get some amount of money back to those that do better outcomes, i.e. the definition of value-based purchasing. So that program really helps drive CMS to the reduction in cost they need, and it's highly likely that well before 6 years that will be the national standard of care. So that concludes this presentation in terms of what we were going to talk about, and at this point we'd like to go to questions.
Thank you, Russell and Andrew, for this great information. So at this time, if anyone has any questions, a reminder that you can type it in. On the sidebar, there is a questions tab. You can just write it there. While we're waiting for if anyone has any questions, I'll remind you that this webinar was recorded, so if you need to listen to it again with all the information, or if you want to look through it again just to make sure that you didn't miss anything, or you want to send it to a staff member, it will be available to you I'll process it once this webinar is over, but it probably won't be able to get to you until tomorrow morning. As you can see on the last slide, the contact information for Russell, Andrew, as well as Renee are there, so I'm sure that you can contact them anytime as well. So again, does anyone have any questions? And is there anything else, Russell or Andrew, that you would like to add?
No, I mean, for those who listen to Andrew, this guy is passionate about his data, I can tell you. You know, I think that you know, I spoke quickly because I wanted to get Andrew, talking about doing a deeper dive in the data. But if you haven't begun to look at the things we're looking at, it's really, really, really important. I can tell you from where I sit in New York and what we do here, working with the state of New York on those work groups. Again, just a little emphasis. We are completely aligned here locally within self-help with what the state's trying to do statewide. And if you're not paying attention to what the state's trying to do in Massachusetts with regards to value-based payment and social determinants of health and clinical determinants of health, you need to, because it's really, really, really important.
Okay, great. It doesn't look like we have any questions at this time, but obviously if I get any, I'll send them over to you. And thank you both for a wonderful presentation, and I hope everyone have a great rest of their day.
And we'd like to thank everyone for spending the afternoon with us. Thank you.
Thank you.
Thank you. Bye.
Bye-bye.
Bye.